one day in one meeting I was a little late, like as I am today. And then I was introduced. We will now ask late Dr. Mehta to speak. So I'm not late, I'm alive. Okay, give me the first slide, please. I think you have gone to the 11th slide. How do I...
Akshay, just...
You have a... Oh, yeah, okay, fine. Go to the first. Yeah. Wiring, especially, there are 2 or 3 situations in which wiring is a special subject. One is that whilst you know very well the wire is a railroad, without wire there is no success, there is no angioplasty at all. So wiring is especially a problem or a challenge in a CTO, and sometimes in a jailed side branch in a bifurcation stenting, and sometimes extremely tortuous vessel. And we talk of a special situations that the rotablation, which I think I heard some few words from Nimit I was talking about using, I think, guideliner and guide extension catheters. So in these situations, but it's very difficult to cover up everything in such a short period of time. So I will mainly focus on the wiring in CTO. 10 to 15% of the cases may be CTO cases in your clinical practice, and many a times the CTO patients are sent for surgery. I can understand that those who can't do the CTOs, they may have to compulsorily send, besides being associated with valvular diseases which require surgery. In any case, I think so. Once the wire is successful, the success rate of the entire procedure is 97.8%. So the wire success is almost a success of the CTO procedure. Few situations in where the wire is crossed but nothing else is crosses is a separate subject by itself, which I can't discuss at this point of time. Now, before you put a wire in your guide catheter, you must study the proximal segment, the missing segment, and distal segment, and then select a wire. Let me tell you that up to the proximal fibrous cap, or up to the lesion, or up to your target point, it should be used a regular workhorse wire to bring a microcatheter there. Without microcatheter, wire should never be used in CTO. It's simple. If you take a dedicated strong wire right in the beginning, the proximal segment may be injured, dissected, and you will call it a day. So it should never be done. Should we be keeping as many number of wires as I have shown in this particular slide? My answer is yes, because there are special situations where which the special wires are needed. Now there are basically 2 qualities of wire: spring coil wires and polymer wires. Here I have shown, is there a pointer or how do I show this? Pointer? Yeah. Okay, fine. If you see here, I have shown in the abscissa the penetrating force. What is the penetrating force? I'll come in a minute to it, but 3 properties are needed for the wire: the tip load, the point of the tip or the tip surface area, and lubriciousness of the wire. On the side here is a family of wire called filter wires. All of them, filter XTA, filter XT, filter XTR, are polymer wires. Polymer is a substance which, when it comes in the contact with the blood or a fluid, becomes extremely slippery. And these wires have comparatively low tip load, except one, and that's called Gladius wire, which has been recently introduced over the last 6 months or so from Asahi. Gladius wire has a tip load of 4, and which can be used where you need a lubrosity or a polymer wire with a little extra tip load for improving penetrating ability. At the extreme end is a Conquest wire. It's a hydrophilic wire, and it's completely hydrophilic except at the tip. Why? So that it can hold the platform well and does not slip off of the proximal fibrous cap platform. So that is how it is. The tip load today available highest tip load wire is Conquest Pro 820, which is 0.008 in diameter at the tip and 20 grams of tip load. And some new wire comes, Estato wire. Those Estato wires and etc. are to be very cautiously used, and in very, very special circumstances, I will not discuss about them. Now, when we move on to the next slide, penetrating efficiency, not the tip load, that I think is a matter of consideration. Tip load is the amount of load that the wire can bear without bending its tip. And it can vary from a low tip load which you use for a retrograde approach like 0.6 Fielder XTR or 0.8 sine wire, or when you want to use a tip load of very high power like Conquest Pro in a hard calcified proximal fibrous cap. Hydrophilicity, which we discussed all about, and we also discussed about the size of the tip. Now, this is in a straight wire. Moment you give a shape to the wire, the tip load is reduced considerably because now the direction of the tip load changes. So therefore this you must keep them. So 12 gram of Conquest Pro with a small tip changes from 10 grams to maybe 10 grams, maybe 8 grams, etc. There are three techniques of wiring: drilling, penetration, and sliding. These all are mixed together. You can't do a drilling alone, you can't do penetration alone, and sliding is automatic due to slipperiness of the wire, and that's a polymer wire. Drilling is usually needed when the proximal fibrous cap is very hard. Gradual step up of the wire stiffness according to the lesion complexity, which we discussed, that you might have to escalate the wire load, tip load, depending upon the penetrating efficiency and the experience of yours. No two wire, I would particularly be using approximately 3 to 5 minutes of the wire, and if I don't succeed, I would say that this wire is not going to be working, and I might want to use certain strategies which may include increasing the tip load, bringing the microcatheter closer to the tip, which also automatically increasing the penetrating power, or I might have to use certain special procedures like anchoring balloon, using a Crusade, a double lumen catheter, which I will discuss by and by. All right, penetration is a blunt entry point. Now you can't do penetration alone. Simultaneously you keep on rotating, and that is called drilling. So penetration and drilling are combined together, and when there is a hard, I think it will not be very useful. You will come to know by your tactile sensation when you start with a simple wire like Fielder XTA, you will come to know that it's not going to be successful, and you might have to go to the stronger wire. Now the strong wires are Conquest Pro here, Crusade XT400, Miracle Brothers 12, and Ultimate. So what is the difference and what should I use? Well, Conquest is my favorite wire for the following reasons. It has a hydrophilic coating except at the tip, and it has a very fine penetrability and torqueability. Miracle Brothers are, and also, they are tapered. In contrast to that, the Miracle Brothers, which is also got a 12 gram tip load, but it is not tapered, 0.014. So Conquest has certain advantage in terms of transmission of a penetrability. All right, so we go to the next one. The highest penetrating efficiency is Crusade catheter plus Conquest Pro 12 wire. The Crusade catheter, which I think somewhere in this meeting will be discussed at some point of time, it is a double lumen catheter. So one wire which is over the head lumen that goes into the side branch, and then wherever it is possible, and that side branch is very close to the proximal fibrous cap, then I think you can use this combination to have a tremendously enhanced penetrability. All right. Now, sliding, I will slip, it's very simple. Fielder XTA. When the proximal fibrous cap is tapered, then it usually leads to microchannel, and there I think the success rate of Fielder XTA could be very, very high. All right. And then what if wire does not cross? First thing, escalate the tip load. How? What is the order in which I can escalate the tip load? We'll discuss. Bring the microcatheter closer to the tip. Closer the microcatheter to the tip of the wire, higher is the penetrating power. Except one thing, very close will take away the torqueability. So you have to keep about 3 to 4 millimeter proximal to the final tip of the wire, and then I think you will have the torqueability, otherwise you will lose the torqueability completely. Anchoring balloon technique, I will show you the example. Parallel wire technique, when the first wire has gone into the false passage and you come to know that you have gone into the false passage only when the wire is visible by outside the distal segment of the CTO, and this distal segment very often is outlined by the contralateral injection, and sometimes if there are collateral by ipsilateral, then you can outline by the one injection itself, and that is a same-sided injection. Otherwise, you will outline the distal segment by the contralateral injection. All right. And Crusade with side branch technique, tornus. Tornus is actually made up of 8 strong wires woven in the form of a rope, and that I think is a very high penetrability. How to use tornus, etc., if time permits, I will discuss with you. All right. So people ask me, why do if I can avoid spending too much of money? You showed me 26 varieties of wire. How do you use which wire? In general, by and large, you can start with Filter XTA. That will give you a feel. And that Filter XTA wire, if it penetrates, that means you have entered a very soft point of the proximal fibrous cap, and it usually would lead to a microchannel, and I think in that kind of a cases are comparatively easy. Functional total occlusion means there is an anatomic passage, but functionally it's not leading to any blood flow. Those kinds of cases, functional Filter XTA is good. Why do I use then ultimately, if that fails, to Ultimate Brothers 3? Why not Miracle 6? Why not Miracle 12? Why not Conquest Pro? Well, we need to have an intermediate wire. Conquest Pro is a very strong wire. Stronger the wire, less is your tactile sensation once you have gone into the false passage. Dissection with the Conquest Pro wire is not uncommon to an very inexperienced person or an operator, because it gives a very little tactile sensibility. Ultimate Brothers is a combination of a good lubrosity, good hydrophilic combination, 3 to 3.5 grams, a gram of weight, and Ultimate Brothers 3 to 3.5 can work as Miracle 6, and therefore I use that very common. If that does not work, then Conquest Pro 12. One exception, you will never use Conquest Pro 12 when the distal fibrous segment or the missing segment, as judged sometimes by your CT coronary angio, then if there is a tortuosity, Conquest Pro cannot take it. It will invariably dissect because it does not accommodate any kinds of tortuosity very easily, because that's the property of that wire. All right. Now I'm talking about a couple of words. When you see this particular steel frame, you realize, first of all, I'll pay an attention. What is my angle? Am I coaxial? Yes, I am coaxial. Then I know that this is a JR4 wire, and that's going to work. That much I know. I will bring the dedicated wire along with the microcatheter. Only I have brought the microcatheter up to this point with a workhorse wire, maybe BMW, maybe blue cyan wire, or you might even use the run-through, whichever is your choice. But remember one thing, do you see that there is a very tight lesion proximal to the CTO? Yes, that I think can absorb the power. It can come as a hindrance, and then this you must keep in mind. Maybe I will go through this into the side branch, dilate this lesion so as to allow the transmission of power completely to the proximal fibrous cap. Moreover, I can put an anchoring balloon here that also will enhance the catheter stability and allow the power to be transmitted to the proximal fibrous cap. Here is the anchoring balloon technique. Proximal wire, the branch has been anchored. While you are doing an anchoring balloon technique, make sure that the artery that you use should not produce ischemia, is comparatively small, comparatively less important. In the side here, in the adjoining slide, I have taken 2 wires. The second wire has got a balloon. When I inflate this balloon, it provides a tremendous power for a use of any hardware on the second wire, which is totally empty. This wire contains a balloon. On top of it, there is an anchoring balloon here, but this I have deflated, and if I want to deliver a hardware, I'll have to remove this because 7 French kite catheter will not accommodate. Well, with this emptying the anchoring balloon from here, I have delivered the stent here. And then thereafter, second stent, how much time I have? 3 minutes? 2 minutes? Okay, fine, quickly. And then I deliver. And this is the final result. And finally, this is, while giving an angle to the wire, every wire will require a small angle. In CTO, this angle required is very small. The distal angle is hardly 1 millimeter. And then you might have to give a secondary curve, especially when you are doing a parallel wire technique. That curve is a little larger, and that we use in a parallel wire technique. Time will not permit me to talk in detail. Here is a case where 2 wires are used. If time permits later at the time of discussion, I'll discuss the details of parallel wire. Both wires are in the false passages, and so I have used the third wire. And the procedure was postponed for that particular day. Retrograde technique also failed, and therefore next day I took on the pilot wire along with Conquest probe. Miracle 6 also had failed, and finally the Conquest probe wire succeeded. Like that, there are lots of tips and tricks to cross the wire in a CTO, and unfortunately time is very short, but I can discuss in question and answer session. Thank you very much.